Rhino, as the name suggests, something to do with nose, and I did mention that they want to settle down at lower temperature, and our nasal cavity provides them the optimum temperature that we have. And they all cause upper respiratory tract infection. And you must have seen yourself, and that's the current information given to the patient, is that this is an infection. Most of the time, it doesn't cause you serious disease. It's self-limited. So that's the key over here, self-limited. And there are more than 100 serotypes, suggesting there's no point making a vaccine, because how would you make a vaccine for 100 serotypes? The most important thing that as a pharmacist or as a drug there for those people who need help, and we did talk about that in immunology as well. Keep in mind that like any receptor, this particular receptor that is required for these rhinoviruses, about like 80% of the cases, have a common receptor, which is also used by Coxsackie virus. It's called ICAM1, intercellular adhesion molecule number 1, which is a family of immunoglobulin superfamily, and this is expressed on epithelial, fibroblast, and B lymphoblast cells. So wherever these cells are located, there are likely chances that these viruses will go and infect and get attached to it. Now, if you look at their structure of rhinoviruses over here, you will see that, let me see if I can use the pointer over here, because it gives me an awkward angle from my side. So you can see this ICAM, right? And this is a virus. And this particular receptor has a N-terminal and carboxy terminal. So it just like throws a noose onto the cells and attaches to that. So if you were to come up with a drug plan, if you were to come up with something that's going to help people resist, especially high-risk people, you may want to make sure that that binding doesn't take place. So that's going to be the most important thing. But I want you to know the intercellular adhesion molecule number 1, and also want to know, and if you paid attention, I just said that it's shared by Coxsackie virus. So that's important for you to know. Now, if you look at the whole process, enteroviruses basically have more liking for gastrointestinal tract, whereas rhinoviruses are unable to replicate in gastrointestinal tract. That's why when we say stomach flu, is a misnomer. So it doesn't mean that the flu, and I myself used to say that, but technically this is not the correct term, but still used by masses. So they are unable to replicate in gastrointestinal tract. They want to stay, and of course, there are a lot of reasons for that. If I ask you a reason, you can tell that the reason is that they want to stay at a lower temperature. The other important thing for this particular virus is that infection can be initiated by as little as 1 infectious particle. So that's also infectivity. So they have a very high infectivity. So if you have it, you're going to pass it on to your neighbor for sure. There's no denying for that. You don't even have to cough at you, sneeze at you, but that's what it is. And a person in the peak of the illness, his or her nasal secretions have thousands of virion per milliliter, right? And then again, as we've been talking over and over again, the most important thing in this case is the immune response that they generate. That's why the common therapy over the counter is antihistaminics. So it kind of releases vasodilators. You got running nose and all these things, symptoms. So that's an immune response that you get. And most of the time, we want to treat them as, giving them with antihistaminics. The other important thing thing is that during all viral infections, you generate a non-specific cytokine response. The most important thing is gamma interferon, or interferon per se, because there's an alpha and gamma. And what happens is, once you generate an immune response to infection, which basically may limit the progression of infection by mounting good immune response, but it contributes to the symptoms. So many a time when you get sick, what it suggests is that your immune system is fighting off the disease. That's what it is. And interestingly, those cytokines which are pro-inflammatory, and that's again a question there, those of you who want to understand where the questions are coming from. So you can see from here, you have an immune response, and it releases pro-inflammatory responses like interferon, but at the same time, the trade-off is that this can promote the spread of viruses by enhancing expression of ICAM1 viral receptors, because one of the functions of pro-inflammatory receptor is upgrade of receptors. And if you upgrade a receptor, you provide more ICAM, and then again, the virus as a receptor for that is going to go attachment to that. Immunity is transient, so there is very unlikely that your first infection will prevent you from having a subsequent infection. And the response basically is also depending upon IgA and IgG, as you can see. And if you remember, when we talked about these IgE responses, we said that even if you have secretory IgA, that kind of response dissipates quickly. And even if you have a immunity per se, that is going to wane over time. So the chances are that you may not get infected by the same virus within that bracket of time, but there are 100 different serotypes, so you may get infected by another set of viruses. So cell-mediated immunity is not likely to play an important role in controlling rhinoviruses. That's why we want to rely on antibody, and one of the reasons is because I just told you about the ICAM1. Okay. Now, this is a typical scenario. You can see that the virus having a receptor over here, and it's going to get attached and then be brought into that. So, and then again, this viruses will multiply, either cause death of the cell, or this we call lysis of the cell, or bud out and be released in secretion. So it's going to attach to your nasal mucosa and proliferate in the nasal mucosa and spread from there. As compared to a bacterial pathogenesis, you can see this is basically a bacterium that you will see that it may have different kind of a what we call response, because bacteria divides by binary fission. So bacteria is dividing extracellularly or intracellularly without the need of your own metabolic processes within the cells. So that's the major difference. If you were to compare viruses over here with the bacterial infection, the pathogenesis, you can see that bacteria is dividing extracellularly over here and both intracellularly, as compared to viruses, which depend upon the cell. They will cause more cell lysis as compared to bacteria. And that's a typical difference between viral pathogenesis and bacterial pathogenesis. And again, it will give you a rough idea that what may be happening. Now, I'm pretty sure I don't need to go into clinical symptoms of common cold. Each one of us have had that, and we pretty much know what's going on. And then we peak our illnesses within 3 to 4 days, and most of the time 7 to 10 days. And you may get prodrome to it. Sometimes people get it more nasal symptom as compared to pharyngeal system. Sometimes it goes deeper into the lungs, as called more of a cough-like. So all these are symptoms of the common cold. The problem is, I want to emphasize on you that common cold is not flu. So that's another misnomer. The first misnomer was stomach flu, not correct. Other thing is if you say, I have flu, but you mean common cold, that is incorrect. They're two different things. Technically, in our medical language, we should not confuse flu with the common cold, because flu means influenza. That is very serious. Okay, but again, having said that, the problem is that it's difficult to kind of differentiate. So if you look at the common symptoms over here, that what's happening to your head, nose, throat, different parts of your body, and you compare them, you will see that some of the features may be standing out. For example, in cold, you may have more, in flu, you will have more kind of headache as compared to cold, which headache may be rare. And then again, if you look over here, cold has running nose, where we have stuffy nose sometimes in the flu. But if you compare all these things, the most important thing that I can tell you from here is that the appetite is decreased in flu because of the infectivity, because of the general response, because flu is more serious. So when something takes away your appetite, you suggest to you something serious is happening that may involve liver as well. The other important thing for comparing cold and flu, I'm pretty sure I'll just copy this chart from CDC, but if you go to pharmacies, you will see all those charts for public information as well. They want public to differentiate between that so they don't get panicky. And again, onset is sudden in flu, fever is very high, whereas you have either no or low grade fever. And then again, fatigue. So fatigue, muscle weakness, high fever, sudden onset is something that should point you towards flu in flu season. So this is something that you have to keep in mind in terms of the differences. But again, it's not easy. Having said that, it's not easy. So there are many different charts and graphs, and you can see from here again the same thing. If you were to look at some other symptoms given over here, again, there are differences between flu and common cold. The most important thing in this particular slide is that it's talking about the cause as well. So when we say flu, we mean influenza. So we're talking about influenza virus, which I will discuss in a while, influenza A, B, or C. When we say common cold, we are talking of either adenovirus, or we're talking about rhinovirus, as we're doing today. And there are some other viruses like parainfluenza, corona. They also would give you a common cold type symptoms. If I was to ask you, which of the following viruses may present as a common cold? And I'm going to list all these viruses over there in this. So you should know this is where it is coming from in terms of differences between these two. The other problem that we see very recently is how would you differentiate between, and these are all very clinically relevant questions, between common cold and allergy. We had the differences between common cold and flu. Now we have common cold and allergy. Again, difficult. So if you don't know the pathophysiology, it will be very difficult for you. So you can see from here, for example, cough is usually with a cold and sometimes allergy. So that's not a big deal. General aches and pain, again, it's not a very clear picture. And you can see usually to rarely, but the most important thing even in this one is that we normally never get fever, should never get fever in allergies. Okay, as compared to cold, again, so if you were to look at those two charts at your own time, you will see that, you guys have anything? Is there something that I can help you with? I thought maybe you're not seeing the PDF, or there's something that I can do it. Yes? What is it? No, I'm talking to these girls. I'm not talking to you. I thought there was something. No, you're okay. You're too far behind my reach. These are the only two lines. I've got short-sightedness. I just look at these two lines. So they sit over there, they drink in front of me, they eat, they talk, whatever they do, it gets noticed. Yeah, it's so obvious. And I have a camera over here as well. So they are the one that they are recorded. So if you want to be popular, you can come in front. They're empty chair. All right. Anyway, so the thing is this, that, I mean, this is again something as a instructor as well, that when you get distracted, I get distracted as well. So make sure that you have a good reason for being distracted. And if there's anything I can help you. So you can see from here, tons and tons of charts over here. And by the end of the day, if you compare all these 4 or 5 charts, and you can send me some other charts as well, all you need to do is to understand the pathophysiology, what is happening, because there are quite a few variables. Even the best of all the physician will have a hard time, I can assure you that. So if you happen to be in a situation, people come to your advice, and don't be kind of blunt, hey, it's fever, it's allergy, it's common cold. There's no simple answer, right? So you have to qualify, make sure that you understand the process. But the best situation is, if I was in your case, I would refer to a specialist or ask them to go and get themselves tested for that. So that's important. Okay. Now, what is the lab diagnosis, and do we need to? So do we need to go for a lab diagnosis for common cold? No. Do we need to get a lab diagnosis for flu? Yes. Do we need to get lab diagnosis for allergy? Yes. Okay. So you can see from here, many times I ask you a question and Ransford tell you the answer is already there. It's unnecessary. Okay. But if you want to do it, just to find out what is the virus, and if it's the same virus and academic interest and so and so, you can do so by looking at the serotype, right? So what we do is we take the virus, grow the cells, and see how good are they in killing the virus. And I give you an example for that, cytopathology, right? And if you remember a term I used, can somebody remind me what was the term, pathophysiological term that should suggest to you this is a viral infection? There was one word I used the other day. Inclusion bodies. So you want to go back and look when you talked about what is an inclusion body. If you look at inclusion body, that suggests the use of viral infection. It's called cytopathology. We can do that, but why should we do that? And many times these are mandated by HMOs as well, not required. Treatment, over the counter, tons of them. No one better than the other, but they are all making money. This is there. And no antiviral drugs are effective, but you can give it to them if the need be. The most important thing is that sometimes we do try to say intranasal administration of interferon. We can do that. And we can also, as I said, something in the pipeline is ICAM, and how can we stop ICAM? But so far, it's more of an academic as compared to clinical. I already told you, since we have a lot of serotypes, and then again, we'll talk about antigenic drift. Did I talk about antigenic drift so far? Antigenic shift or antigenic drift? Okay, so that's something that we will talk about in influenza, very important concept. But the most important thing is that right now, we are not doing anything more what is being offered by, the over-the-counter drugs, okay? And then again, best sanitation, your books talks about that. I don't know, vericidal facial tissues, whatever. So there are some of the things which are in research, some of the things which are out there for you to make best use of it. And I'll stop here and jump to the next lecture because I'm already late on one lecture. And while